mistaken. In chapter 22, looking at respiration, we left off at mentioning these gas laws. Like I said, if you're going to go into respiratory therapy, you're going to get into more detail on these laws, and you're going to learn that there's going to be information about stuff that's like going to be considered partial pressures, because you're going to see like something that says it's got like the P and then O2 or P, CO2, that sort of thing. That's going to be talking about partial pressures.
This will also be pretty important if you take any like chemistry, any other like chemistry courses. You're always going to like talk about gas laws.
Yes.
Especially like partial pressures.
The gas laws, because they're laws, okay, they are going to apply in a lot of different areas of science. So when you're looking at them for our purposes, we're going to see that this one, okay, for partial pressures, that you're going to see this term. Your textbook gets into a lot more detail, but for our purposes, I wanted you to understand what that P might mean in front of the O2 or the CO2. So it means the partial pressures. And if you add them all up, it gives you something called a total pressure. And those are going to be values that get applied to different respiratory tests that can be done, and you will actually see like the partial pressure of oxygen and so forth in patient charts. The other one that we're going to be looking at today is called Henry's law, because of the fact that we have that respiratory membrane. If you remember, when we were looking at the structure where we have an alveoli, and because it has tons of those capillaries, in between that alveoli and a capillary was what was called the respiratory membrane. And one of the things about it, it's water-based. So we're going to need to understand how these gases are going to be able to exchange between the capillaries and an alveoli based on how soluble they are in water. Based upon if they do they dissolve easily, readily, and therefore move easily. So we're going to be seeing Henry's law because of the fact that the overall goal of respiration is to make sure that we move these gases. And did we get to this one right here, where we're based on the respiratory center in the brain? Okay. And these neurons that are present, they're going to be on what's termed a reverberating circuit, because it's continuously active. So as we look at this movement of air, just like we've seen with a lot of other topics that we've discussed, we're going to always have something that can affect the movement of the air. And so for this respiratory system, once again, we're going to have something or things that can affect resistance. When we look at this movement of the air, we're going to see that pressure affects airflow. Now, that means pressure either here, outside the body, or pressures inside, okay? So we don't have just pressure in the lung tissue. We also have atmospheric pressure. The greater the resistance, the slower the movement of air that occurs. We're going to find the diameter of the bronchioles plays a part. If you remember, when we were looking at the lungs, okay, and we start out with the trachea, go into the bronchi, as those bronchi branch into the lobes of the lungs, and we continue to branch and branch and branch. 2 lobes on the left, 3 on the right, okay? And as they continue to branch, when they get to that, as they get smaller, smaller, and smaller, we're going to hit bronchioles. Bronchioles were smooth muscle, all right? So this means the autonomic nervous system will affect this smooth muscle. We refer to it, once again, dilation or constriction. And then we have something called pulmonary compliance. How easily do the lungs and thorax expand? Now think about this for a second. The thoracic cavity, the movement of the thoracic cavity. We've got muscle in between the ribs, and we've got the diaphragm. They didn't move very easily. Do you think that could affect the ease at which the thorax expands?
Yes.
Yes. Also, we're going to see that the lung tissue itself is very elastic. So anything that will affect the lung tissue is going to affect the ease of expansion. These would be factors that are going to affect the flow of the air in and out. Now, when we look at ventilation, if we're thinking about those alveoli, what I refer to as the little grapes, and don't forget, those grapes, they're surrounded by the capillary beds. In between that membrane of the alveoli and one of these capillaries is an interface, the respiratory membrane. So, to ventilate in this alveoli means the air that's going to make its way all the way down, all the way down, all the way down to one of the grapes. Once we have air in the grape, we now have a volume, because that's what they refer to the air, okay? We now have a volume that can be exchanged. They measure this. It's based upon, of course, per minute. Think about your beats per minute and so forth. We have a certain number of respirations we should have on the norm per minute. Okay? Y'all ever bother to count or think about it? Yeah. Okay? When we look at this system, because not all the air gets to the alveoli. What? Wait a minute. Okay. Well, think about these areas right here. Nasal cavity, pharynx, larynx, trachea, bronchi, bronchioles. It's actually making its way to an alveoli. So that is termed dead space. That's air that can't be exchanged. In other words, in this movement that's taking place, we're not going to see like this air get exchanged until we get it to an actual alveoli. So they call this anatomical dead space, because the air is stuck in different anatomy. Does that make sense? Okay. Our physiological dead space. Physiological dead space, is there any area in an alveoli that cannot exchange the air? The answer to that, yes. Under normal conditions, good physical health, chances are, with no other disorders, respiratory disorders, or anything like that, you're not going to have a lot of air not getting exchanged. Chances are, this number, this amount, is going to be low. But what about somebody that may have emphysema, COPD, edema, fibrosis? Do you guys remember that? What does it mean, Brian, for something to be fibrotic?
It means that you have extra like fibrous tissue growing on organs or tissues.
And it makes that tissue not function. So certain disorders, certain diseases, they can scar the lung tissue, make it fibrotic. If it's fibrotic, it can't move. So we're not getting exchange. But under normal conditions, all of these factors have a normal number. We measure it. We're going to measure the function of the lungs. It's called spirometry. It's done with a spirometer. What we're looking at is we want to measure the ventilation, the movement of the air taking place. A lot of times it's done for certain diseases or disorders that are present. But have you ever been around somebody who might have had surgery? All right, and they come out of surgery, what do you see sitting maybe on the little rolling table beside their bed? Do y'all see one of those? Okay, why?
They want to put under anesthesia, you're basically breathing for you, so your body kind of stops breathing itself, so they give that to you so that you can start expanding and actually focus on your body breathing and getting back to its normal rates when they put in.
Yes, when you go under anesthesia, especially general anesthesia, yes, that means all areas of the body are pretty much being, they're actually using other means to like keep you breathing and so forth.